And my good friend Henry would have been absolutely thrilled and delighted to be here, except that he had knee surgery just 10 days ago and is still recovering, so wasn't able to make it. So what's going to happen today is we've changed the order ever so slightly so that I'm going to go first, and then our two guest speakers are going to follow me. And maybe I can introduce them to you now. I'm going to talk about the background of OTC use and say something about the evidence of efficacy. Terry Maguire is a pharmacist from Belfast. He's both an academic and a retail pharmacist. So he brings to us today an intensely knowledgeable view as to what, as it were, happens when people go along to try and buy their OTC analgesics. And Ángel Lanas almost needs no introduction. He's professor of gastroenterology at Zaragoza in Spain. I didn't say that right, but I can't do it. Quite Zaragoza, better, yes. He's intensely interested in football, which is a shame because he comes from Zaragoza. And he knows more about the safety of drugs than most people I know. Anyway, look, we've got an hour and a half. What we're going to do is we're going to take all the questions at the end, and all the questions, by the way, can be done via the Ethic app. There's no other way of doing it, I think. If you go to the Ethic app, you can ask questions, you can tweet them to us. It comes up on a screen here, and then I can ask them at the end. And if all else fails, just run to the front or maybe try and find a microphone. But we will try and do it that way, right? Because we are being technological. Okay. Let's talk about some issues about OTC and definitions, first of all, because it's not straightforward. And one of the things I'm aware of is that the definition of what is over-the-counter or non-prescription varies very widely, both geographically and temporally. And so that in the United Kingdom, for example, and in Europe, what is available OTC has changed very much over the course of the last couple of years. The definitions vary. There's a thing called the General Sales List, which means in the UK, at any rate, that you can buy analgesics anywhere from a petrol station or a supermarket. Then there are pharmacy medicines, where you can get them from a chemist only, but I'd have to go to ask Terry and say, Terry, I want this medicine. And he would say, well, since it's you, Andrew, no. Or words to that effect. And for the purpose of this talk, we're using OTC in a most general sense. There's another issue as well, and that is the issue of dose. Most of the time when it comes to tablets, we talk about using 2 tablets, so that might be slightly different. Since we're talking about some other OTC products as well, doses are quite difficult things to pin down when it comes to over-the-counter medicines. But for just to make a point, I've been going to these meetings now for donkey's years, and I don't think we've ever had a meeting on over-the-counter analgesics before, and yet a huge proportion of our populations do use over-the-counter analgesics for one reason or another. I'm sure most of you have got a little bag with you in which you've got all the medicines you use for your headaches and so on. So a few brief words about pain and analgesic use. In Finland, for example, this is typical of many. What one finds is that if you survey people experiencing pain over the last week, what you find is that OTC analgesics are very high on their list of things to use, as well as exercise, prescription medicines, or going to see a doctor. And there the drivers were moderate or severe pain, several painful locations, that might be true in older people, daily or continuous pain, and that slightly worries me that people are using analgesics for continuous pain and for chronic pain lasting for 3 months or longer. I'd much prefer some of these for seeing a doctor. The volumes of OTC analgesics are really rather large, difficult to pin down because a lot of companies with OTC analgesics don't want to tell you what their sales figures are. But there was a report from the American College of Preventive Medicine in 2011, which was reporting that, excluding Walmart, there were 711 million packed units sold for coughs, colds, and allergies, most of which contained an analgesic. And in addition to that, another 430 million packed units of analgesics sold as analgesics. And the Royal Pharmaceutical Society in the United Kingdom claims that about 200 million packs of OTC paracetamol are sold every year. And if you put these together and you divide them by populations, you get a rough and ready idea that on average per person, we're consuming somewhere between 3 to 5 packs of analgesics every year, without actually defining here what a pack is. Now, in the United States, you can buy ibuprofen and paracetamol in jars of 500 tablets. You can't do that in the United Kingdom and many other places. And even in the United States, some things are changing. There is actually some very definite data that came out of the UK when some years ago the pack sizes for paracetamol were reduced in order to prevent so much of the paracetamol overdose and liver damage that we were seeing. And on the right there, you can see consumptions there for a variety of years for paracetamol, aspirin, and ibuprofen in terms of millions of tablets. And the one I really like is the table here, which shows the same sort of information, but in tons. And for people who are used to working in micrograms or nanograms or picograms, to see drug weights in tons is a novel experience. But you can see there's a lot of it about. One of the most interesting things is the attitude of people about analgesics. Most people don't know what's in their analgesics. In the United States, it was in Utah, I don't know that makes much of a difference, half of the 1,000 emergency department patients did not know that Tylenol, a popular brand, actually contained paracetamol. And huge proportions didn't know that any of 7 common analgesics which they were buying by brand, they didn't know that they contained paracetamol. And the majority had no idea what the maximum daily dose of paracetamol was, and only 1 in 7 knew what the correct dose of daily dose of paracetamol was. So you can see there's a vast degree of ignorance there in the United States. But it's not confined to the United States. It's exactly the same thing in the UK, where again, looking at an emergency department patients, you find that half of them, and this is London by the way, half of them thought that ibuprofen contained paracetamol. Now, this might to you, and certainly to me, seem slightly mad, but this is a sort of replicated research that we're getting, and I'm sure Terry will come back to this as well. And there's also this recognition that the paracetamol content of many medicines we buy, particularly for coughs and colds. I've got a bit of a cold. I used something called a Lemsip this morning. It's got paracetamol in it. And I did know that. So thank you for Reckitt Benckiser for one of my favorite drugs. And again, only 1 in 2 knew the correct daily dose of paracetamol, but 1 in 20 thought the maximum daily dose was 10,000 milligrams a day. You've really got problems here with public understanding of what their analgesics are all about. People misuse analgesics, and this is certainly true of sports people, it's true of soldiers in training, it's true of university students who frequently take paracetamol and ibuprofen, and large proportions will sometimes or always exceed the maximum daily dose. And there are issues, and Angel is going to talk about safety in short-term use of analgesics. But it's worth pointing out that even though we think we know most of the safety issues around analgesics, there are people like Nicholas Moore, my namesake in Bordeaux, with his SALT trial, was able to say, well, hang on a second, guys. Even with people who are not overdosing on drugs like paracetamol, you see with paracetamol in non-overdose cases, twice as many cases of acute liver transplantation that you do with NSAIDs. People's attitudes to painkillers are really interesting as well. There's a study done in Macclesfield. There are others. People coming into an emergency department asked about what their attitudes were. Only a quarter had taken an analgesic even though they had pain, 75% had not. And the reasons for that are variable. They're about things like don't like taking tablets or worried about side effects, which is a strange thing. You're going to the hospital, or you've run out of tablets, or the pain wasn't bad enough, or we came straight here. Thought there'd be a problem because considering I'd been drinking, surprisingly only 4%. Didn't want to mask the pain. I was surprised that was quite so low. And these sorts of reasons are common. But the interesting thing is if you ask people to judge their satisfaction with treatment in the emergency department, it is treatment of their pain, which is by far and away the thing that is most important to them. So I've now given you Henry's talk. I'm going to proceed to mine. What I'm going to do is to just give you a flavour of the evidence that we've got for OTC analgesics. And I'm going to take most of my information here. I'm going to concentrate on acute conditions, and I'm going to take the data mainly, not all, but mostly from Cochrane reviews, which have been done over the course of the last 10 years or so. And I'm going to talk about acute pain, I'm going to talk about headache and migraine, and I'm going to say something about topical analgesics as well. So, you know, there are a large number of reviews and even overviews on some of these things. For example, in acute pain, we're looking at single-dose oral analgesics. We've now got 3940 reviews with over 50,000 patients involved in over 400 trials, all reporting the same outcome over the same period of time and with pain measured in the same way. So we've got at least for some areas, we've got some fairly stable evidence on which to base judgments about the differences between different analgesics. And for what it's worthwhile considering the situation you get in a typical acute pain trial. You can see in red here in acute pain trial what happens with placebo, where down at the bottom, less than 15% of people get, I beg your pardon, where most people, 70% of people, get less than 15% pain relief, and very few, about 10%, get really good pain relief there at the top. And then if you give people an analgesic, and a good analgesic, it's reversed. So we're converting people who are getting low levels of pain relief to people who are getting good levels of pain relief. And I don't particularly want to show too much about numbers needed to treat here, but we can also calculate success, which is an easier way of doing things. What we consider success can be calculated in this way. If you've got 100 people who are being treated, maybe 10 of them will have got better with placebo anyway. So the maximum that your drug can do is 90. If your drug actually does 45, then that 45 is half of the 90, so you're 50% successful. For those of you who like numbers needed to treat, what we can say is success rate and numbers needed to treat are obviously correlated, so that the lower the number needed to treat, the higher the success rate. But even though I might show you some numbers needed to treat, I like success rate because it's a currency that I can apply even to some of my best friends who will understand it. He said, looking deliberately at various people in the audience. But, you know, it is something that we can use generally with good effect for patients and for ourselves, knowing that it's related to things that we want to do. He said, falling off the podium. I was talking earlier on about what constitutes a useful result, and you know, in most of the areas that we're looking at, we've got clinical trials and systematic reviews which are giving us results in terms of outcomes that patients want, which is about 50% pain intensity reduction or having no or mild pain. So in single-dose acute pain studies, that's 50% of maximum possible pain relief over 6 hours. In tension headache and migraine, it's having no or mild pain at 2 hours, although others are available. And for strains and sprains with topical analgesics, it's a 50% pain reduction at about 7 days. So I'm going to show you some quick results for acute pain, headache, and strains and sprains. But I'm going to say first of all what's missing, and there are gaps in our knowledge. For example, there is little or no evidence of efficacy for low-dose combination with paracetamol or aspirin. We have looked, and we keep on looking, but and we're sure that there are trials which have been done in a dim and distant past, but which were never published. And this is despite some heroic efforts that were made at doing this in Oxford 25 years ago. So there are gaps in our knowledge, that things that you can buy in the chemist, which frankly we can't tell you anything about. There are rubefacients for strains and sprains and muscle soreness. There's very, very little evidence there. And for adverse events in general, although Angel is going to talk specifically about this, by and large, you don't see serious adverse events or common adverse events much different from placebo in these clinical trials, but these clinical trials are not designed to detect adverse events. You need to go to different sources to get that. So let's look at acute pain. First of all, in a league table of numbers needed to treat. As you know, 1 is the perfect answer, where everybody gets better with treatment and nobody gets better with placebo, and 5 is not so good. And here I've assembled from the Cochrane reviews numbers needed to treat. And where there is a change in color is the point estimate, and the bars are the 95% confidence interval. And for some, like ibuprofen acid, 400 milligrams, we've got very tight confidence intervals because we've got masses of data. And what you can see is at the top, we're getting combination products, ibuprofen and paracetamol, and fast-acting formulations, particularly of ibuprofen. Ibuprofen and caffeine is there because it's not available in Europe, it is available in South America, and you can always take your fast-acting ibuprofen with a very strong cup of coffee. Diclofenac is there even though it has been withdrawn from some parts of the world, but is still available in others. And dexketoprofen actually is there as well, because that is available over the counter in Spain and Italy and some of the Baltic countries. But you can see, generally speaking, that we've got some drugs which give us very low NNTs, with NNTs below 2, and others which are not as good. So, you've actually got some spread of efficacy there. And at the top, what you see is that we're getting about 70% of people getting success with the best analgesics, whereas with aspirin or paracetamol or low-dose naproxen, it's down at the 10 to 30%. And you as a consumer can make a choice, and pharmacists giving advice to consumers know how they might be able to interpret that for them. In migraine, these are all over-the-counter medicines in most of the parts of the world. We again got numbers needed to treat from about 3 to 6. And it's interesting that ibuprofen, and that's ibuprofen acid, we believe, for most of those is towards the top, then sumatriptan, then aspirin, paracetamol, naproxen, and diclofenac. Here, this is for the outcome of mild or no pain at 2 hours. Our success rates are lower, about 40%. And I don't think it gets massively better than that, even if you go into drugs which are available only on prescription. The International Headache Society approved outcome is that of no pain at 2 hours, and then when you look at that, because it's a much harder outcome to achieve, the numbers needed to treat increase. As you can see, the order changes ever so slightly. Sumatriptan is now better than ibuprofen, but our success rates are now down at about 20%. So there's limits as what we can do. And I know there was a workshop yesterday Lars Benson helped run about tension-type headache. We've worked with him on Cochrane and other reviews on tension headaches. And the simple fact of the matter is in tension-type headache, certainly it's my belief that we have a problem. Namely, that most of the tension-type headache studies are done in people with really quite frequent headaches, which might not be the same as the sort of headache that you get, which is when you're taking your very occasional tablet. And there's a dearth of data, multiple outcomes, very difficult to pull it together. And the best we can do is success rates which are moderate. But for mild or no pain at 2 hours, ketoprofen, which is not available OTC, is okay, and paracetamol is not doing bad. So, you know, we think that we can be doing something there. The more exciting area, perhaps, is topical NSAIDs for strains and sprains. This is a topic we've been doing reviews on for 20 years or more and continually updating them. And in its latest incarnation, what we've been able to do is not just look at different drugs, but different formulations of drugs, the sorts of things that you can get over the counter. And we've been able to look at gels and creams. Gels are better than creams. And at the moment, we're beginning to see that diclofenac and ketoprofen gel are better than ibuprofen gel. And actually, the success rates are actually rather good. With diclofenac gel, it's up to 70%. So our take-home message is this. We've got lots of evidence about OTC analgesics in various forms, in various formulations. You know, and that's been a big advance in the last 3 or 4 or 5 years. We don't have information on everything, and most of the information, certainly I've given you, is about efficacy and not about harm. For oral analgesics, combinations and fast-acting formulations seem to do best. And for topicals, NSAID gel formulations seem to do best. So, pile of evidence, a pile of information, all of it is valuable to consumers. And the next question is what happens if I, as an ignorant consumer, goes into a chemist shop and asks the chemist, well, I've got such and such a pain, what should I do? Terry, would you like to come and tell us?